Hi, I want to talk about disseminated intravascular coagulopathy, or DIC for short. DIC. DIC, or disseminated intravascular coagulopathy, is a rare but very serious life-threatening condition. The condition causes abnormal clotting throughout the blood vessels and later on can lead to bleeding. It develops quickly over hours, or sometimes might be slowly over days. The pathogenesis here would be essentially that there must be a cause like sepsis, inflammation, pregnancy, and so on. At first, overactive clotting leads to blood clots, and that will occur throughout the blood vessels. This can lead to ischemia or infarction of many organs, including that of the heart leading to heart attack or the brain leading to stroke. Later on, the overactive clotting process will use up platelets and other clotting factors. And after that, there will be bleeding. And the bleeding will be seen all over the orifices and even underneath the skin, giving Petechiae, Purpura, or Ecchymoses. What are the possible causes of disseminated intravascular coagulopathy? Number one cause is sepsis. If you want to enjoy this, because I don't want to waste your time going into details over sepsis right now, just check my channel for sepsis. I have two presentations on sepsis alone. Check Total Vicar for sepsis. Okay. So sepsis, severe tissue damage, which could be secondary to burns or trauma of any sort. The number third cause of DIC is pregnancy, particularly if there is experience of Abruptio placentae, that is, the placenta has detached abruptly from the fundus of the uterus before the baby is delivered. So it's a sudden occurrence, and that could lead to DIC. Amniotic fluid embolism is another possibility in pregnant women that may eventually end up with disseminated intravascular coagulopathy. How about cancers of various organs, various tissues? They can lead to DIC. Retained products of conception. That's why when I was talking about possible causes the other time, I mentioned pregnancy. Retained products of conception, like someone having either therapeutic or non-therapeutic abortion, and the entire content is not evacuated from the uterus, the retained product could lead to DIC. Also, in case of delivery and placenta is not completely detached and then removed from the uterus, if it is retained there with time, the woman can come down with massive bleeding and DIC. What are the possible risk factors there? Sepsis. Like, while talking about causes, we mentioned sepsis, right? Okay. Sepsis, that is a situation where there's inflammatory response to infection. Infection caused by either bacteria, virus, or fungi. How about injury? Injury to the liver causing liver cirrhosis, injury to the pancreas causing pancreatitis, severe trauma, burns, or even major surgery. How about street drugs? This is surprising, right? Well, cocaine and ecstasy could cause disseminated intravascular coagulopathy. No wonder. People that are indulging in cocaine and ecstasy use could come down with stroke, like ischemia, and so on. Aortic aneurysm. We all know what aneurysm is all about. Okay, and large hemangiomas. Cancers. Cancers like pancreatic carcinoma, cancer of the gastrointestinal tract, particularly stomach, colorectal or colorectal carcinoma, or hematological related cancers like leukemias and lymphomas. How about heat stroke? During hot weather, people can come down with heat stroke. I have made 2 separate presentations on heat stroke, and you can check my channel for that. I actually made mention of this possibility while talking about the clinical features. Check Total Vicar for heat stroke. I'm going to get 2 presentations already published on heat stroke. Okay. Still on risk factors. Abruptio placentae I've just explained a while ago. Amniotic fluid embolism, just explained also. Postpartum hemorrhage and blood transfusion reaction, particularly massive blood transfusion and organ transplant rejection or snake venom. Well, I will talk a little bit more about snake venom. It's a situation that no one prays to have. I've seen it, that the individual will have massive bleeding underneath the skin and orifices. And the 2 cases that I saw actually died because they presented late, and with the anti-snake venom that we gave, everything could not save the situation. It was massive, massive hemorrhage everywhere. Snake venom. What are the clinical features? Could be asymptomatic, and might be asymptomatic if the cause is chronic or cancer in origin. The acute situation would develop over hours or just few days. The chronic ones will occur very slowly over a long period of time. So either acute or chronic, once the symptoms are manifesting, you'll see the following. Bruising, that is over the skin. Somebody might even be accusing someone else of slapping or kicking or hitting him or her. That is actually disseminated intravascular coagulopathy. You see Petechiae, see Purpura, or Ecchymoses. You can see surgical site bleeding, particularly someone who had not developed DIC before having surgery, but after all, because of one thing or the other, so many factors like inflammation and overwhelming sepsis, after surgery, or massive blood transfusion, and so on and so forth. DIC sets in, then check the surgical site one, you're going to see bleeding there. Bleeding from orifices, like I've said, from the nose, from the mouth, rectal region, and so on. Gum bleeding while brushing teeth might be the first clue in most people. And melanous stool, that is black tarry stool, as an indication that there's bleeding from the upper gastrointestinal tract, staining the stool. Hematochezia is bright red blood per rectum. That could be as a result of lower gastrointestinal bleeding or even massive upper gastrointestinal bleeding. Hematuria will be picked while the individual is urinating and we'll see blood there. It's just going to be bleeding everywhere, right? Still on clinical features, when the heart is responding, there might be chest pain, shortness of breath, dyspnea, decreased blood pressure, and of course, increased heart rate. Still on clinical feature, there may be confusion and slurred speech. Pain, redness, warm swelling of the lower limbs, and raja, that is in women with heavy bleeding, scissors. Now that is showing that the central nervous system and of course the inflammatory process is going on here. So no organ is spared. What are the possible serious complications of disseminated intravascular coagulopathy, on account of which many may actually die if not treated appropriately and timely for that matter? Acute respiratory distress syndrome, okay, gastrointestinal tract bleeding, myocardial infarction, or commonly called heart attack could occur. Respiratory failure, and of course renal failure. All these could be the cause of death within hours or few days. Pancreatic failure, seizures, or stroke. Adrenal failure leading to Addisonian crisis, and electrolyte imbalance everywhere. And of course, blood pressure is also affected. Still on possible complications, splenic failure, heart failure, shock, stroke from ischemic stroke, or even stroke from hemorrhagic stroke, venous thromboembolism leading to pulmonary embolism, or deep vein thrombosis leading to pulmonary embolism. How do we make diagnosis here? The first thing first, we have to take history. When we are suspicious that this is the situation at hand, we need to rule out all probable risk factors and probable causes that we can actually get from the history. Sometimes we may not be able to get some from the history except the laboratory report is out. Then we have to carry out a physical examination to check for bleeding or clots or possible complications all around the entire body of the affected person or persons. We have to rule out thrombotic thrombocytopenic purpura with ADMTS13 assay, and deficiency of which will give a clue to TTP. ADMTS13 stands for A, disintegrin, and metalloproteinase with thrombospondin member 13. It is a von Willebrand factor cleaving protein. So the assay of that is pretty good in centers that are sophisticated enough to be able to run that. Once we're able to run ADMTS13 and is low, we'll know we are dealing with TTP, thrombotic thrombocytopenic purpura, and of course the skin will show the purpura. Liver cirrhosis or liver failure. Then we have what we call liver function test. The liver function test will include the level of albumin, bilirubin, INR, APTT, and glucose. I'm going to check for blood urea nitrogen and creatinine and electrolytes, trying to rule out renal failure. Still And laboratory, I'm going to do PT or INR. PT or INR is the same. And APTT, like I've said, in liver failure or liver function test. Then we are going to do complete blood count. Even if you cannot do complete liver function test, you have to do or INR, then APTT. Please, you just have to. Then we have to do complete blood counts, platelets, von Willebrand factor, fibrinogen, fibrin degradation products, and it would be nice to have peripheral smear for schistocytes. It's very, very important. And you can include the D-dimer to rule out DVT or VTE, as the case might be. There is what we call DIC panel. Okay, I have gone beyond DIC panel. But if you're in a hurry or it's an exam, you can't remember many things. DIC panel, PT or INR as one, APTT, fibrinogen, D-dimer. You will have to do that, and of course, you can add your von Willebrand factor. So, but if you have the time, like I do right now, yes, still DIC profile is platelets. So let me reitemize them. PT, APTT, platelets, fibrinogen, D-dimer. Those will constitute DIC panel. Okay. Treatment. The treatment will involve that will treat the identified cause of causes or risk factor of factors. Then we get our anticoagulants at hand, heparin, low molecular weight heparin. Warfarin will not be the first thing to use, but for maintenance after all. Some people will be so confused that we're talking about bleeding, and we want to, give that woman or man heparin. Report the use of aspirin. Okay, replace fibrinogen, and you can use cryoprecipitate, fresh frozen plasma, and of course platelet transfusion. Oxygen saturation level must be known, and you give oxygen if it is low. We are going to reevaluate periodically. You check vital signs almost every 30 minutes, and you do physical examination almost every 1 hour. And of course, we're going to follow up after the individual is okay to go home. Then follow up must include going over the entire risk factors again. Then we're going to repeat clotting factors assay. Okay, we're going to check factor 8, factor 9, factor 10, factor 2, or liver dependent clotting factor. Actually, we are going to rule out possible liver pathology aside the sepsis, trauma, pregnancy-related products, and so on. Do you know why? Almost all clotting factors are produced in the liver except two. The two that are not produced in the liver are von Willebrand factor and factor 8. The rest are produced in the liver. So the liver is a big master when it comes to clotting regulation in the entire system. We're going to check out for some subtle signs, and signs of what? Stroke. Okay, because I've said earlier that today, as far as pathogenesis is concerned, the first thing that will occur will be the overuse of the clotting factors leading to deficiency of the same, Later, that will lead to bleeding. But before we see bleeding, ischemia would have occurred. And with that, we can have ischemic stroke. But that is not really now possibility of hemorrhagic stroke later on. So stroke, we should watch out, because that may lead to disability for a long period of time, on account of which the doctor might be sued by the patient. Well, it's not really negligency, but we need to be proactive. So for stroke, check facial drooping, pronator drifts of the arms, and of course the speech that will be slurred, and immediately call 911. I'm going to check for possible heart attack. Is there any lightheadedness or dizziness here? Any chest pain? Any chest discomfort? But let me pause a bit here that chest pain is not the sign that must be picked before we can suspect or actually make the diagnosis of myocardial infarction or myocardial ischemia, as the case might be, because there is atypical presentation. There's what we call silent ischemic attack, and I will advise that you check my channel because I have produced a separate video on silent ischemic attack. So the chest pain may not occur in the elderly, someone that is being diagnosed with diabetes mellitus, women, or somebody who had surgery around the chest, particularly cardiothoracic surgery or related, along that line in the past. Someone with coronary artery bypass graft may be having heart attack without necessarily complaining of pain. And women most of the time can have chest discomfort, not classical chest pain that radiates to the neck, to the axilla or jaw. So check for shortness of breathing, nausea, vomiting, tiredness, back pain, shoulder pain, jaw pain, or most times maybe asymptomatic. And with that, come to the end of this life-threatening condition called disseminated intravascular coagulopathy. You can leave comments on my channel, and I will please implore you to please subscribe to my channel so that you can get these presentations immediately they are published. Hope you gain 1 or 2 things. Thanks.